I'd like to welcome all of you to the second annual National Women in Surgery Career Symposium. This year's program promises to build off the synergy created last year at this time.
And if you just take nothing else away from this, think about this for 1 second. We still accept students based on their science GPA, their MedCats, and their organic chemistry performance. But somehow we're amazed that doctors are not more empathetic, communicative, and creative. Now, as kids would say, duh, and then we put them through a residency, and I don't mean to be at all demeaning to surgery. It's not that GYN is that much more, but there's not a whole lot of, let's hold hands and be empathetic. So it's not a huge surprise that as part of my grant that when we did this, we found that almost all responders felt insecure about the future of medicine. Almost all felt that they had little to no management and leadership training in medical school and residency. And over half felt that their clerkship and residency director wasn't really interested in their personal development.
But what about the starting point? What about medical education? How are we doing getting women into the field of surgery? As all of you are aware, there are new trends that make this really important. Women now make up 50% of the graduating medical students. Fewer men graduate from college than women now. We comprise 60% of undergraduates. But it's interesting that there really is a significant change in this percentage when it comes to the women who are interested in surgery as a career choice.
At Northeast Ohio University, 21% of students that underwent a telephone survey said that their family or significant other would deter them from a surgical career. And that survey also showed that students would be more likely to pursue a surgical career if exposed earlier on in their medical education and had earlier exposure to positive role models.
So we wanted to know from the students how this negative perception of surgery could be changed if they felt that there was one. And now in the free response section of this question, we did get some harsh criticisms. And remember, these are students that don't have formal clinical experience and training. And I just want to remind everyone, these are quotes directly from students. So one suggestion was for a less hostile environment. Another is that it's not the perception that's the problem, it's the fact that the negative perceptions are valid. One said surgeons could help by not acting like jerks. Another, I think the negative perception has some basis in reality. So to change the perception, you need to change the culture of surgery when the environment is indeed negative.
So choosing a mentor, I think this is a key part for all of us in our careers, whether they be careers in private practice or academics. And I would say it's not necessarily a mentor, singular, but mentors, plural.
So people have preconceived notions that research is it's dreary, it's drudgery, it's not fun. Au contraire, it's the thing I look forward to every week. Otherwise, you run into the pitfalls of just running patients down an assembly line, and that's not why we're here.
Was that we expect women to be non-aggressive. That when we're trying to think about how we can get patients to be more compliant. Women are perceived to be non-aggressive, and when women act aggressive, this could negatively impact our expectations of them and lead to patient non-compliance. Male physicians, on the other hand, are expected to be more aggressive, so if they act nice or if they act a little bit more aggressive, it's no big thing.
Discrimination in the workplace, as all of you know, still exists even in 2011. Indeed, every state in the U.S., every state is an employee at will state, meaning that you could be fired at any time for any reason, with or without notice, with or without cause, except if it's an illegal reason.
Patients wanting to be able to see surgeons or physicians that look like them. I think we have a real disconnect here between this column, which is the U.S. population, and this column over here, which represents U.S. surgical faculty. And I think we also know very clearly that the numbers of people of color in this country continue to rise, and that is not changing anytime soon.
So and I use the word quote, in the good old days, I trained in the boys club. And the boys club at the time was every other night call. I took 2 months of call in the house without going home, working for Dr. DeBakey. I took no days off when 2 of my sons were born. In fact, I was castigated for even asking for the day off of the delivery. That's the way it was. That's for real, and it's not that long ago.
for the 2010 study, more than 4 out of 5 nurses have concerns about the shortcuts, the incompetence, and the disrespect that occurs in our hospitals.
So be flexible, admit you're wrong, never listen too much, be yourself. You're going to see a bunch of selves here. We're all very unique women. Sense of humor works. I have a very good one. You have to enjoy it along the way. If you're doing 50% of the time something you like to do, that's a good job. Okay, don't look for 100. Those complaining in your office, that's job security. Okay, that's what they're paid to do. You have to keep your family in the loop. I did have to have dinner with my husband last night because I'm staying over to give Grand Rounds Monday. So that was what I gave. And Nancy already gave me grief saying you wanted it all to come and you weren't here. And I said, I'm here now to make that happen. And then look at every crisis with your heart and mind. Every disaster really can do you well, okay? And lately there's been lots. But look at everything with your heart and mind.
I was doing some work at Merck about women in leadership, and one of the women talked about the importance of having a truth-telling supportive network. That is, people who will tell you, you didn't handle that well. Or as I listen to you, I see you're getting caught in the same, kind of myopic perspective. So you need to have truth tellers in your supportive network as well. A coach.
There are some intuitive impressions. Women have smaller hands, they have good fine motor skills, great attention to detail. Perhaps for some of these higher tech things, less physical strength requirements, well suited for minimally invasive techniques for a variety of reasons, and that some of the minimally invasive procedures may have some lifestyle advantages in terms of patient recovery times and outpatient practices, or relatively speaking, a higher percentage of outpatient practices.
It's achieving balance between your professional and your personal life. And this is something I gave a lot of thought to. In particular, I gave a lot of thought to it between 3 a.m. and 7 a.m. on Friday morning when I was up with my sick 22-month-old child the night after I just spent 14 hours in the OR. And it made me think about how hard it really is for us as female surgeons to achieve balance. It's something we're always striving for. And I did title this talk A Work in Progress because I do think for most of this is an evolution of finding balance.
This is all these year-round, full-time working men and women. And for those women, men, the wage gap is 23 cents. We earn 77 cents. The wage gap for women surgeons and physicians is 36 cents. It's huge.
First and foremost, pick an important unsolved clinical problem. Not something that people don't care about, but something that people care about, something you care about, something you're passionate about, and also a problem that may not just take 1 or 2 years to figure out, but 5 or 10 or even your whole career. This should be your driving force.
So just a few quick personal tips. Try only to do what you want to do or things that will get you what you want. No matter where you are, there will be politics. It's best to learn how to deal with these early. Pick your battles. Not every battle needs to be fought. Usually the ones in the operating room are not worth it. Just learn to work within the system. And then accept responsibility only if it's matched with authority. If they want to give you a nice title and you're supposed to be, picking up on when everybody's doing bad things, but they won't give you the authority to do anything about it, don't take that job.
The purpose of my talk today is a follow-up from studies we did last year. You may recall we did some surveys that actually created quite a bit of controversy. There were 2 survey studies we did. We surveyed female physicians and did they encounter bias during their training and residency, and about half of the practicing physicians felt that they'd encountered some kind of bias, often from other females, nursing staff. At the same time, we sent out another study about nurses' attitudes towards female physicians, and there was a little bit of a disconnect there because nurses were uniformly positive about female physicians, and we thought this was interesting, and it created a little bit of controversy. In the discussions of these 2 studies, several physicians in the audience, such as yourself, feel free to come up and make suggestions such as this afterwards, suggested we do a study about referring physicians. Is there a gender bias?
committee. We want to thank everyone who attended, but also the speakers, and we all really felt it was just such a wonderful experience, taking the time to come down here and talk with us, making yourself personable and approachable, and we just greatly appreciate it. But also, none of this really could have happened without Dr. Roth, and we would like to present her with a plaque and also a photograph of the planning committee with all the photos we had taken.